I think we're live.
We are?
It says so on the TV screen.
Yeah. Is that okay, Felipe?
Yes. We are live.
Yeah.
Posso começar? May I start?
Yeah.
Ok. Bom dia a todos e todas. Eu sou a professora doutora Sandra Maria Lima Ribeiro, da Universidade de São Paulo. Na USP, eu sou docente dos programas de pós-graduação em Nutrição e Saúde Pública, da Faculdade de Saúde Pública, e do programa de Gerontologia, da Escola de Artes, Ciências e Humanidades. Dentro desses programas, eu sou responsável pela disciplina chamada Fragilidade do Idoso, Prevenção e Intervenções relacionadas à nutrição e à atividade física. Nessa disciplina, hoje eu tenho a honra de receber dois renomados pesquisadores para a nossa discussão, e por isso ela está sendo aberta a todos vocês interessados. Muito obrigado por estarem conosco. Well, today I have the great honor to have here two renowned researchers to whom I'm very grateful for sharing their time with us. The first one is the Professor John Edward Morley. Dr. Morley is a professor of internal medicine in the Division of Geriatric Medicine at St. Louis University School of Medicine in Missouri, USA. Dr. Morley has edited more than 20 books and published more than 1,400 papers about the role of neuropeptides in the modulation of hormonal responses and behavior. Clinically, John Morley focuses on diabetes, nutrition, frailty, sarcopenia, cachexia, and cognitive assessment. Thank you, John, for coming. I will introduce the second speaker, Professor Ivan Aprahamian. Dr. Ivan is a geriatrician, associate professor and chief of the geriatric residency program at the Jundiaí Medical School, São Paulo, Brazil. He is also an honorary fellow in the University of Groningen in the Netherlands, and also he's an affiliate professor of the Frailty and Multi-System Dysregulation Group at the Geriatric Divisions in Johns Hopkins University Medical School, USA. And besides, both are fantastic and generous persons, and most importantly, I consider them as my great friends. Thank you both for coming, and we start with Dr. John Morley. Dr. John, please.
So I'm happy to be here, both with Sandra and Ivan, who are good friends. I have to apologize because my Portuguese is non-existent, so I think you will have to struggle through English, but I realize, having been to Brazil many times, most Brazilians speak better English than I do, so we will do fine. I'm going to try and share my slides now, which we hope will go smoothly, but let's see. Okay, share. Okay, now I've got my screen. I've still got you guys on the screen. Let's try the Chrome tab. Share. Oh, come on. Let's see. Okay. Nope, that's not going to do it. Or maybe I can. Let's see if I can.
Yeah, that's right now.
Well, the world, yeah. You should be able to see my screen now. Is that correct?
Yes.
Okay, so now I will go ahead and start. I apologize for my total incompetence at sharing screens, but this is live. So I'm going to be talking on physical frailty. I will focus on the interactions after an introduction between the peripheral body and the central parts of the brain. So just to start off, when I talk on frailty, I love to do this Dr. Seuss poem. I cannot see, I cannot pee, I cannot chew, I cannot screw. Oh my God, what can I do? My memory stinks, my hearing stinks, no sense of smell. I look like hell. My mood is bad, can you tell? My body's drooping, have trouble pooping. The golden years have come at last. The golden years can kiss my whatever.
John, sorry.
Yeah.
We can see your slides, just your screen. I suppose you did not open your slides.
Oh, you can't see the slides?
Yeah, no, only the screen.
Oh dear. Okay, okay, so.
Hi, John.
Hi.
I think you shared your screen, not your presentation. If you open the share screen again, you have one option to share your screen, and to then you can select your PowerPoint presentation instead of the full screen. Okay.
Okay. It says stop screen. It says share. It doesn't give me a lot of other choices. Okay. Now I'm going to push share. Do you get my slides when I share the screen?
Not yet.
Screen sharing screen sharing works best on some screens let you share audio. Look for share audio checkbox. It doesn't say that. Follow these steps to share the video. It's not a video. Don't show these steps. Share screen. Okay, I'm pushing share screen. Now my screen is there. You can't see my screen, right?
No.
Let me try. Now I push share. Let me try down here.
John, I think I discovered here. So you have to open the PowerPoint in your screen. Don't maximize. Just open the software. Okay. Then you have to go to the share screen. You click again share screen, not video files, and when you click again share screen, you're going to have three options: full screen, an application screen, and another option. You have to click in the middle, application screen, and then you're going to see your PowerPoint, and you double click and then share.
Okay, I've got screen sharing is easiest with two monitors. That doesn't help. Screen sharing works best on a good computer. It's not a bad computer. Some screens let you share audio.
No, you can just click share screen now, and then it will open another option, and you click in the middle, application screen.
Okay, that one. Let's see.
You saw it. It's you can see Microsoft PowerPoint, for example.
Okay, can you see it now? Can you see my slides?
Yeah.
We made it.
You just have to put in presentation form.
Okay, but you can see the slides or not?
Yes.
Yeah.
So we can do it without my face and we can go.
Yes.
Okay, so we got through the poem, which you didn't need to see in writing. So let's go on now to the next one. So this is the first use of frail.
John, sorry.
Yeah.
We can see all the slides at the same time. You have to change to the presentation mode.
I did. This is the problem.
You did it? Oh.
Yeah, let me go back to stop sharing and start again. Okay, what can you see now? You can just see me, right?
Yes.
Yeah.
Professor John, sorry for interrupt.
Sure.
First, you need to do a small configuration on PowerPoint, because if you share the window, it's easy to do a small configuration on PowerPoint. So follow with me. Open your presentation on PowerPoint, please.
Okay, it's open.
Now, on the top, on the tab, slide presentation or showing presentation, it is configure the presentation. You see that?
What? Wait a bit. What am I looking for?
On PowerPoint, 1 minute. You can see on the top a tab with the design, transitions, etc. This slide presentations. You see that?
I've got start the show. Let's see over this side. On the right-hand side or the left-hand side?
Na esquerda ou na direita?
On the top, at left.
Yeah, so I've got a screen there. Is that what you want me to push?
Yeah, I need to configure the slide presentations. So,
how's that?
I'm sorry, because mine is in Portuguese, so it's a little bit difficult.
Okay. Mine just has a picture, so it's even harder. But can you see the screen now?
Not now, not yet. You have to share the presentation firstly.
Oh, okay.
But
So now I'm going to go back
a lot
to the
easier.
Okay,
To make it a lot easier, you can do.
I'm going to push share. Okay, share screen. It's share screen. Okay, share screen. And now, okay, so I've shared my screen. Now I'm going to go back to the PowerPoint and see if that works. How's that?
We can't. You are not sharing yet.
Not working.
Okay, so I did the share. I went to my PowerPoint. There's a save. There's repeat. Yeah.
You can
wanna
go to the PowerPoint tab menu. Okay.
Yeah.
You see PowerPoint, file, edit, and so forth. Go to the right. You're going to see presentation. Let me see mine here. It's presentation, slide presentation. Slide presentation. Click on the option.
So I've got
you have,
let me get out of this one.
And you have a slide menu, and you have to go to presentation configuration.
So what I've done is I've got the choice to share the screen. I can see you guys, then I push share screen. Theoretically, it should work. It tells me that
share window, no share slides.
Huh?
Share screen, share window, maybe.
Okay, let me see. Share screen. Yeah. So window, let me try window. Any better?
No.
We can see all the slides at the same time.
Well, wait, I might be able to fix that one.
Yeah.
If you can see something now, you should see it. Can you see?
We can see all the slides at the same time.
Because I can see only one slide. Now you still can see all the slides?
Yeah.
No, I can't see. No, now I can.
You can see what? All the slides?
All the slides, yeah.
Okay.
Not the presentation format, you know.
Let me see if I go there. How is that?
The same.
All the slides.
Okay, so I've tried the two things.
Maybe, John, and how about you maximize your PowerPoint and
Sorry. can you try presentation? My brother is sending me the instruction. Presentation mode now.
Yeah, it won't work, Sandra. That's the problem. Something is blocking the presentation mode. So, John, how about maximize PowerPoint, and instead of presentation mode, you just see each slide in the maximum format, zoom in each slide, and I think
Oh, now it's working. Wow, finally.
Okay, I'm not going to touch.
Don't touch.
Okay. So
thank you so much.
It's better.
Hopefully, you can all see things, and it will go forward. So, as I was going to say, this is the first presentation I can find in PubMed talking about frail elderly. It was done by Helen Hayes, one of the early geriatricians in Canada. She was doing mainly palliative care, and she was talking on frail elderly and the terminally ill and the Canadian family physician. And her message to all of us is take each day as it comes and try to do the best you can. You never know what challenges are on the horizon. And we found out today just getting a PowerPoint to work is a challenge on the horizon. So now let's go forward. Okay. So when we think about the management of frailty, it's very similar to sending a woman or a man to Mars. It is very difficult. And it is not only difficult, but it's complex. And managing a frail older person, either at home or in hospital, can be extremely difficult. And many of us do this very poorly. So at the background, when I first got into geriatrics, we used to be interested predominantly in disability, and we had two types of disability: the activities of daily living, which was Sidney Katz's in 1963, and instrumental activities of daily living by M. Powell Lawton. After that, the Battelle Index came along, which was a little more complex, put the two together, but was not well used. And in Japan today, the Kihon Index is very similar to a combination of the Katz and Lawton scales. When I started geriatrics, basically at the time, it would be 1985, when Larry Rubenstein published his paper in the New England Journal. Larry was my junior faculty at that stage. And basically, we knew that if you spent a lot of time with older people, you concentrated on the functional problems, you could actually lower mortality, decrease discharge to a nursing home, and improve function. But this was only for about a year. After that, people tended to do poorly. A little later on, in 2002, Ken Rockwood in Canada went ahead and developed his frailty index, which is a massive comorbidity index more than anything else. It's similar to the Charlson index, but it has 40 to 80 components. And the other thing he did up at Dalhousie University in Canada was he came up with this diagram and said, if you look at this diagram, you can tell who's frail. Now, Ken is most probably one of the best clinicians I know, and he can look at people and do this. For most of us, we can basically struggle and put them into 1 to 3 categories and don't do very well. Similar to Ken's index, when I was in Australia with Renuka Viswani, she wanted a short index to look at people in nursing homes, and we came up with a frail nursing home scale, which is very good for picking up people who need palliative care. So let's look now at what the components of successful aging are and what we can do about it. So the World Health Organization likes to talk about resilience, which is the capacity to recover quickly from difficulties, toughness. Not easy to measure. And if we think of it, the way I like to think is we have normal physical function going on to successful aging. And at times something goes wrong and we become frail. So let's look at what happens with frailty. So if you're a football player and playing soccer anywhere in the world, you peak somewhere around about the age of 30. After 30, what happens is that you start to go downhill, and you go downhill fairly quickly at the highest level of playing football. So by the time you're 40, most people cannot play professional football anymore. And if we look on the right-hand side here, you can see that it's exactly the same with what happens with VO2 max, cardiac output, balance, muscle strength. They peak somewhere around about 30, and then they go downhill. And basically, if you do exercise, you can slow this down and not get to the frailty threshold as quickly. If you get disease, you go down more quickly, and then you go to the disability threshold. So the definition for frailty is it occurs when, under stressful conditions, the person has diminished ability to carry out important practice, social activities of daily living. It should be distinguished, I believe, from disability. And you can see that Renoir, who was very disabled, could paint the Blondello Rosa, which shows that he was not frail despite being very disabled. There are criteria for successful definition of frailty. These were originally developed by Rockwood. I've changed them a little, but you've got to look at content validity. It includes multiple determinations. It should be dynamic. Validity validly supersedes earlier successful definitions. Broadly useful across contexts, for example, in clinical trials, population studies. I think importantly should be easily administered in a clinical setting. Construct validity is more common in women than men. It's more common with age. And importantly, it's a precursor of disability, and it's causally related to factors that produce aging. And then the criterion validity predicts mortality and predicts other adverse outcomes like delirium, falls, worse function. When we're looking for this operational definition, here's from the Journal of Gerontology Consensus Conference. It's a clinical syndrome. It is not disability. Increased vulnerability in which minimal stress can cause functional impairment, might be reversible or attenuated by interventions, mandatory for health workers to detect it as soon as possible, and it's useful in primary care and community care. So the first of the physical frailty definitions was developed by Linda Fried and her colleagues at a number of universities on the East Coast of the United States. And she sent it to the New England Journal. They rejected it, and I met her at a meeting. She was upset that the New England Journal didn't like it. And I said to her, well, just send it to me at the Journal of Gerontology, Biological Science, Medical Science, and I promise you we'll accept it if it was good enough for the New England Journal. And we accepted it, and it became the most highly cited paper in the Journal of Gerontology, Biological Sciences. It's basically what she said is if you lose more than 10 pounds of weight in a year, if you say you're exhausted, if your grip strength is in the lowest 20%, walking speed the slowest 20%, and if you have low physical activity in the lowest 20%, you're going to be physically frail. In a healthy population over the age of 70, the cardiovascular health study, she found that about 7% of people had physical frailty, and that females were more likely to be physically frail than males. Remember that males die much earlier than females, but females get more physical frailty. And so you see there the Johns Hopkins Hospital where they do their aging research. So here are some of the studies. One of Linda's early studies showing that people who are frail have a progression to hospitalization and intermediate somewhere between the non-frail tend to be rarely hospitalized. And another study done in the Hispanic Apese in the United States showed that people who were frail were much more likely to have deteriorations in activities of daily living and to become and to die. So all of this is fine, but it all takes a lot of time to do. And we were interested in how could you quickly get a primary care physician to make the diagnosis. So I was at a meeting in Barcelona and basically got really bored because most of the people were talking about Rockwood's frailty approach, which, as Ken knows, I don't find very exciting. And so I wrote down on a napkin fatigue, resistance, aerobic, illnesses, and loss of weight. And I said resistance is climbing a flight of stairs, aerobic is being able to walk 1 block, illnesses, more than 5 illnesses, and loss of weight greater than 5% 5% over 6 months. And I said 1 or 2 would be frail, 3 or more would be frail. And there are now over 35 validations, actually over 40 validations in the literature as a predictive index in the future. So Leon Flicker in Perth saw this definition. He thought this was very nice, and he sent a paper to the Journal of Clinical Endocrinology and Metabolism showing that low testosterone in males predicted frailty, and he was very happy with it. But the reviewers sent back and said, Leon, you've done a very nice study showing that testosterone predicts nothing because there is actually no validation for the frail scale. So Leon went ahead and validated the frail scale in Perth, Australia. That was the first validation, and he showed that frailty in males was related to a low testosterone. In our studies back in St. Louis, we looked at our young population in a African-American group living in a very poor area, and who somewhere between the ages of 50 and 65 behave much more like a group of people in other areas, 65 and beyond. And we showed and compared the frail to other indexes, including the cardiovascular health scale and Rockwood, and we showed for the prediction of ADLs, frail was much more predictive than any of the others, and mortality was also predicted very well by frail and equivalent to the others. So this seemed that it predicted fairly well. Gina Wu in Hong Kong looked at the specificity of the scales, comparing them all. And what you can see here with mortality and physical limitation is that they all are very similar and have very good specificity. None of them have good sensitivity. So we have to recognize that this does not say for sure that this is what you've got. It says that it's highly specific in predicting poor outcomes. And this is the European Male Aging Study. They use the frailty index, the frailty phenotype, and frail scale. They basically looked at people 40 to 79 years and followed them up for 4.3 years. And compared to robust men, those who were frail at baseline had an increased hazard ratio, and it didn't seem to matter which one they looked at. Their data, they said, suggested that the choice of a frailty model may not be of paramount importance when predicting future risk of death, enabling flexibility in the approach used. So at about this time, the aged care minister in Australia, Ken Wyatt, recognized that the frail scale would be very good to use in primary care patients. He said that frailty screening is the canary in the coal mine. If you pick up frailty earlier, it can be a game changer by early intervention. And he thought that this was a safe, simple, inexpensive, practical intervention, and suggested that the frail screen should be used in all older people at least once a year. Theo, who works with Rockwood, came up with a meta-analysis where she looked at the effects of exercise in frail, and what she showed is that exercise increases functional performance, increases walking speed, increases chair stand, increases stair climbing, increases balance, decreases depression, and decreases fear of falling. And you need at least 45 to 60 minutes 3 times a week with an 80% of 1 repetition maximum with 3 sets of 8. This seems to be about what you need to reverse frailty, no matter which of the definitions are used. So we came up with an algorithm to approach the management of frailty. And if on the frail scale you say you're fatigued, you need to look to see if the person is depressed. You can use the PHQ-9 or George Grossberg's AMSAT. It doesn't matter, but you should look for it. And the next question is, do you stop breathing while asleep? And obviously, it's your bed partner has to be able to tell you this, or somebody else. But if you have sleep apnea, and it turns out that for fatigue, about 10 to 20% of people who are older who complain of fatigue have sleep apnea. And remember, over half of these have central sleep apnea, so you can't tell by just saying, well, they've got a big neck. Then there are things like hypothyroidism, B12 deficiency, anemia, and hypotension, orthostasis, all of which produce fatigue. The next two, the resistance and aerobic, tell you they're sarcopenic. And here you need to do resistance exercise, aerobic exercise, 3 to 5 times a week, and need a protein supplement, ideally a high leucine essential amino acid supplement. When you look at the illnesses, the reason to have illnesses in is if you've got illnesses, physicians love to give you a drug for everything you complain about. It's most probably the single worst behavior of physicians throughout the world. They say, you've got something wrong with you, you need a drug, they give you a drug. And many years ago in a VA population, we showed that if we just took people who were on more than 8 drugs and we basically reduced the drugs, we reduced hospitalizations, to a lesser extent, we reduce deaths, and basically side effects of drugs are a major cause of frailty. And then finally, if you have loss of weight, there are many reversible causes of loss of weight. I remember them by using the Meals on Wheels mnemonic, which is medications, emotions, depression, elder abuse and alcoholism, late life paranoia, swallowing problems, oral problems, nosocomial infections, wandering and other dementia-related problems, the endocrine disorders, enteral problems such as celiac disease, eating problems, low salt, sugar and cholesterol diets, and stones, cholecystitis. When I got my gallbladder disease, I lost 70 pounds over a 7-week period, partly because I was a physician and stupid, and thought, well, it was nice because I was overweight that I was losing weight. And secondly, when I worked out that I had gallstones, I spent about 3 weeks looking to find a surgeon I would trust. Eventually, I gave up and took any surgeon because I realized that I was going to die if I didn't have my gallbladder out. And then after my gallbladder was out, within 6 months, I put back on most of the weight. So let's look at what happens in frailty. And much of frailty, as you can see at the bottom, is basically a combination of sarcopenia being the major cause of frailty. And you have to recognize that people who are sarcopenic will be frail. You make the diagnosis of sarcopenia by using the SARC-F, which is strength. Can you carry 10 pounds? Do you need assistance in walking? Can you rise from a chair, climb stairs, or fall? And basically, sarcopenia is characterized by muscle loss, decreased strength, decreased walking speed, decreased bone mineral density, decreased body weight. The increased SARC-F is the quickest way to make this diagnosis. Again, much more specific than sensitive, but can be done quickly in a primary care healthcare professional's office, and I think should be done regularly on all older people. So we recognize that as we get older, there are changes in muscle fiber size, fiber grouping, and we see an increase in muscles with myosin heavy chain, with aging and denervation, all of which occur. It's similar to, but different from amyotrophic lateral sclerosis. One of the things that's been shown is with aging, somewhere between what happens with motor neuron disease and with healthy subjects is sarcopenic subjects have a decrease in the motor unit number index, suggesting that much of the sarcopenia is due to problems at the neuromuscular junction. So what about the biochemistry of frailty? The longest lived animal is the bowhead whale. It has limited disease and frailty, lives for about 200 years. A single gene, the ERCCC1 gene and the proliferating cell nuclear antigen gene, are linked to DNA repair as well as cancer resistance. These genes work very well until right at the end of life in the bowhead whale. Also, environmental frailty is very important. You see the polar bear there, stuck on a piece of ice with nothing to eat, and he's slowly fading away and becoming frail. Now, let's look at this biochemistry that produces frailty, genetic instability, lack of telomeres, epigenetic alterations, loss of proteostasis, deregulation of nutrient sensing, mitochondrial dysfunction, cellular senescence, stem cell exhaustion, and altered intercellular communication. The reason I'm going through all of this is we spend lots of time finding people saying there is one cause of frailty, there's one cause of aging. It isn't. There are multiple causes. And if we don't look for all of these causes and try to do precision medicine, we have poor outcomes. So with aging, the muscle biomarkers we can use are creatinine kinase, aldolase, coenzyme Q, MLC1. Troponin T is most probably useful. Creatine correlates with muscle mass. Myoglobin tends to go up with aging. Creatine to cystatin C ratio goes down in a J-shaped curve function, and N-terminal peptide 3 collagen also goes down. So multiple muscle biomarkers can be used to show that the muscle is no longer functioning. And another one that is being shown is C-terminal agrin. Agrin plays an important role in structure and function of the neuromuscular junction. And about 30% of people with sarcopenia have elevated C-terminal agrin fragments, saying that their problem is predominantly neuromuscular and not muscular itself. So now we come to what's important, and that is what happens to make us frail and how do we communicate these problems to the brain. So Henry David Thoreau, who has got about an eighth of his picture on my screen, says, "Methinks that the moment my legs begin to move, my thoughts begin to flow." And this connection has been well described in many places. We know that within the brain, changes in neurogenesis, neuronal maturation, angiogenesis, hippocampal volume, learning and memory all lead to fatigue. And we know that muscle sends multiple messages in the form of neurotransmitters and hormones, and also in peptides to the brain, which alter those functions and lead to fatigue. These include insulin growth factor 1, brain-derived nerve growth factor, cathepsin B, fibroblast growth factor 1, irisin, and most importantly, tryptophan, which is increased when muscles work poorly, and when it gets to the brain, is turned into serotonin, producing fatigue and depression. If we have problems with the heart, there's decreased blood flow, which leads to fatigue. Out here on the right-hand side, you see I put troponin T, because if there's damage to either heart or peripheral muscle, troponin Ts tend to go up. They leak from the muscle. And then finally, if your lungs are not working well and you have low oxygen tension, you will develop fatigue. In the movie Cool Hand Luke said, "What we have here is a failure to communicate." And frailty is a failure to communicate between the different organs in the body and also the brain. An important factor involved in frailty, and we showed this many years ago when we were looking at our frail scale, is basically there are elevated inflammatory cytokines in frailty. The most repeatable of these is the tumor necrosis factor receptor 1. is much more repeatable than the interleukin-6, which people have said is the one that you should look at. And also CRP, C-reactive protein, also goes up with frailty. Recently, we've been looking to see if we can find other biomarkers, and Andy Wynn in our laboratory is interested in progranulin. And what he showed is basically progranulin is an excellent marker of frailty. Why is this? Well, progranulin goes up when you have elevated cytokine levels. It appears that its major function is to dampen out the increases in cytokine level. And so not surprising that it is a good biomarker for frailty. We see many hormonal changes with frailty. These include basically testosterone, which we talked about originally. DHEA is also down in frail people, IGF-1, and vitamin D goes down. But if you're going to measure vitamin D, you need to look at the free or bioavailable vitamin D, because depending on the color of your skin, your vitamin D normal levels are very different. So if you have a very dark color skin, your body has genetically changed so that the binding hormone for the binding protein for vitamin D goes down. So if you come from equatorial Africa, you have very low levels of binding protein. So your vitamin D level is very low, but the free or bioavailable vitamin D level is normal. So if you're going to use vitamin D, measuring 25-hydroxy vitamin D by itself is most probably a waste of time unless you've got a very, very white skin. We're looking at other things that have been shown to be associated with failure, with frailty. Circulating osteoprogenitor cells are one. They produce laminin A, which alters the cell membranes and causes problems with the cell membranes. And low levels of these in frailty are associated with both muscle and bone frailty. Tissue glycation, as happens in diabetes or as we get older, we know that the sugar molecule will combine with a protein, produce the shift base, which we learned about in medical school, Amadori product, and the age proteins, the advanced glycation end products. And these advanced glycation end products divide to cause activation of the age receptor binding, which will lead to free radical generation, inflammation, and metabolic and structural effects, and also will basically alter cardiovascular, diabetes, kidney disease, Alzheimer's disease, sarcopenia, rheumatoid arthritis. And this is also helped by age increasing the cross-linking proteins. So this is a very nice paper that appeared, I think, in one of gerontological aging. And what it says is, look, when we're looking at frailty and aging, it's multiple things. You can't just say it's one thing. So at the top, they have inflammation, then they have mitochondrial problems with apoptosis. They point out that calcium homeostasis can do this, fibrosis can do it. They point out that the change in the neuromuscular junctions and neurons can do it. And interestingly, like us, they found that progranulin was a major component of this. Cytoskeletons, the cytoskeleton and hormone interactions are important in frailty. And then there are other things. The message here is multiple things cause frailty, and therefore, when you're looking at somebody who's frail, you've got to look for multiple causes. Finally, in experimental gerontology, they looked at the role of microRNAs in both muscle and mitochondrial in the pathophysiology of frailty. And basically, these microRNAs play a major role in the epigenetic control of aging and frailty. They are associated with impairment in older people, leading to frailty. And the circulating microRNAs are multisystemic biomarkers of frailty. So when we come through the end of the first part of this, basically, physical frailty is an important medical syndrome. The group in this consensus definition defined physical frailty as a medical syndrome with multiple causes and contributors that is characterized by diminished strength, endurance, and reduced physiological function that increases an individual's vulnerability for developing increased dependence and or death. And remember, you've got to do precision medicine if you want to make the diagnosis. This is multiple things are causing this. The recommendations from the consensus conference were physical frailty can potentially be prevented or treated with specific modalities such as exercise, protein calorie supplementation, ideally leucine-enriched essential amino acids. They said vitamin D, though the data to support vitamin D is much less at this stage, and a reduction of polypharmacy. So frailty is now objectively defined and can be treated and can be simply screened for in the clinic by using the frail. There appears to be some utility of also looking at a psychosocial frail scale, and we'll talk about that in a minute. One of the things that we have got very aware of is cognitive frailty. This is from the latest study in Italy, where they found that people who had vascular dementia basically had worse cognition, worse executive function, depression, falls and balance disturbances, urge incontinence, functional decline, and disability. And people with Alzheimer's disease have the same sort of changes. They walk slowly, they're more likely to fall, their balance is worse. And the combination of depression, physical frailty, and problems in the brain tend to lead to cognitive frailty. And we need to recognize that when we find somebody who's frail, we need to look at what's going on in their brain as well as peripherally. We have done some excellent studies, or we, I should say, the people in Perry County have done excellent studies on basically dementia with and without exercise. Perry County is about 100 kilometers south of St. Louis. And when you look at this, you can see that if basically you go ahead and you do exercise with CST, you markedly improve the SLUMS, St. Louis University mental status exam, much better than you do if you do just the CST, the cognitive stimulation therapy alone. You basically also improve quality of life, you decrease depression, and obviously you also improve basically things like 5 times sit and stand, functional reach, and timed up and go, which are measures of fall risk. So when we start to put frailty together, while I focused on physical frailty, we need to recognize that there are also other things that cause frailty. There's a psychological cascade: depression, cognition, anxiety, fear of falling, fatigue, and health perception. All will lead in the end to physical frailty. Social factors, environment, basically, if you live near a freeway, you're more likely to be frail. If you live in a bad neighborhood, you're more likely to be frail. If you have a poor income, if you've got no support system, health literacy is not very good, and if your activity isn't very good. And then we've talked in detail about all the biological causes of frailty. These all come together. Frailty is pre-disability, pre-functional deficits, and it's important that we recognize that early diagnosis of frailty allows us to try and prevent it to going on to functional deficits, hospitalization, nursing home admission, and death. Working in the National University of Singapore with Professor Merchant, we have actually developed an iPad version for screening for frailty, which will also look at some of the causes of frailty. And they have done this in over 2,000 people, found it a very useful thing to do in the elderly outpatients, having somebody do it before they see the doctor. And we have gone on now and developed what is Aging Successfully computerized program. We know that the older population is rapidly increasing. There are a limited number of geriatricians, and yet many preventable geriatric syndromes that are missed often by primary care healthcare professionals. And in the United States, the government pays for the annual wellness visit, and yet it's only done in 1/5 of people by healthcare professionals. So we thought if we could put together a computerized approach where we use the data collection equivalent to the electronic health record, but we took the data as it was collected and used it to ask other questions and produce a diagnosis and then give recommendations for treatment. We have this together on the background of telehealth. So this cuts down the cost because of lack of fixed costs for doctors' offices. But more importantly, this can all be done from home. And then we have developed a whole series of special products such as exercise, a loneliness program, and the cognitive stimulation therapy that can be delivered by telehealth. So we're trying to say here that this is very important and that this is part of the future, that we're moving away from the doctor's visit taking place in the doctor's office, but much of this is going to be done by a computerized robot. This is just showing you the outcomes that we get. We look at multiple things with this computerized visit, and if it's in red, that means there's a problem, and the patient and their doctor will get recommendations of what should be done to improve their outcomes. So what we've tried to tell you in about just under an hour is that basically, if you look at this, you can see that as we get old, we start to be like the very young child. We have problems with our walking, and we have disability. And it's important that if somewhere as we're starting to have problems in our 60s or 70s, that the physician recognizes this and treats this, we can slow down the development of functional impairment as we get older and make people live longer. So this completes the first part of my talk, and I've left time for questions. I'm a little scared to stop sharing because I may never be able to get back. But if there are questions, if you can ask them, and we can try and answer them. Otherwise, I'll go on to talk about COVID frailty. Sandra, are there any questions?
Okay, there is no questions in the, yeah, there is one question here. It's on the screen. Can you see, John?
I can't see them, no.
Okay, I'll read. How to identify sarcopenia or frailty in a patient who had depression and fatigue? This is the question.
Okay, so a person who has frailty, the way we define it using the frail, will also have basically problems with their functional status, i.e. they won't be able to walk properly, they won't be able to climb a flight of stairs, and that in itself is important. Loss of weight is the other thing. But in somebody who says they frail, you've always got to look to see if they've got fatigue. And if they are fatigued, you've got to look for the causes of fatigue, because you're treating depression. Now, in the study I showed you from Perry County, when they treated depression, when they treated the frailty with exercise and they treated the cognitive problem, they decreased depression. So we have to pay attention to multiple things. And this is the whole point of precision medicine. You've got to say, if this person's got depression, they need treatment for depression. But if they've been depressed for 6 months or a year, they're also going to have physical frailty because they haven't been exercising, they haven't been doing things. And so you start to put it together. The same thing is with cognition. We strongly feel that cognition stimulation therapy we've shown is much, much better than when coupled with exercise and with any of the drugs available at the moment to treat Alzheimer's disease. So we think that should be the approach. This was originally shown at the University College of London by Martin Orrell and his group, and really it's hardly available. We've just in the United States put on the market a very expensive drug for Alzheimer's disease, which I think will just kill people earlier and not do any good. I'm hoping I'm wrong, but the literature, the studies look really bad for it, and that's the antibody. And we're prepared to pay huge amounts of money to give this drug to people, but we don't put the money in to do cognitive stimulation therapy and exercise. In the States, when you need exercise, the doctor said, well, go and do some exercise. You know, if you're really lucky, they may give you something like the Very Frail out of North Spain, which is a very good set of exercises for people at different levels of frailty. But most of the time, the doctor does none of this. He just says, go and do exercise. And if you're like me, somebody says, go do exercise. I say, sure, I don't have time, and I don't do it. So you actually have to have the exercise classes. You have to get people into them. You have to get people into the cognitive stimulation therapy classes. You need to get them into loneliness classes if they're lonely. You've got to pay a lot of attention. The treatment of an older person is multiple things done by multiple health professionals and also volunteers. And if you don't have those things in place, you don't fix physical frailty. So the reality is these things all overlap, and you know, cognitive frailty is very common. So if you don't look for cognition in a frail person, you're not going to treat it, and they're most probably not going to get better unless you put in some effort to improve the thought process. And particularly in moderate to mild cognitive stimulation therapy makes a big difference to cognitive dysfunction. I don't know if that helps, but I hope it gives you the idea that what I'm trying to say is this is not easy, and this requires a family of healthcare providers, including volunteers, to really fix somebody who's frail. But if you fix them, you markedly decrease costs to the system. And I think that's where the government should be putting all their money instead of into the newest drug, which may or may not make any difference.
Okay, thank you, Dr. Morley. And next we are going to talk about COVID-19, right?
Yeah.
Because I need to choose the questions. So one more question before the second part. Is that okay?
Oh, sure, whatever you want.
Okay. The question is, since inflammation is a component of sarcopenia and frailty, would dietary modulation play a role in preventing and treating this condition? The person is interested to talk about other nutrients than protein, right?
Yeah. So the answer is most probably yes. You know, we've done studies with alpha-lipoic acid, for instance, and it will decrease inflammation. The problem with it is it also increases the rate to death. So, you know, the anti-inflammatory vitamins most probably play a role, but not in small amounts. If you give large amounts, you tend to decrease the inflammation, maybe improve the quality of life. You certainly can improve function in mice because that's where we did most of our study, but you have to be realistic that you may be accelerating death. So not an easy answer at the moment, but it is feasible that the anti-inflammatory vitamins will make a difference. Not enough good studies to say this is true, but enough to say that it's worth trying, but don't give huge amounts of excess. This is true of almost everything in aging and medicine. If a little bit of a medicine works, we tend to increase it until it develops a side effect. And people tend to think of vitamins, anti-inflammatory vitamins, as not having side effects. They have a number of side effects, and we need to be careful not to overuse them. I don't know if that's helpful.
Okay, we have a lot of questions. I don't know what you prefer, to continue your talk and then we open to more questions at the end. What do you prefer?
Why don't you do some more questions? I can go very quickly in the COVID frailty, which is basically just an example of how you get frail. I mean, COVID is a wonderful example of how everything goes wrong, so we can do that fairly quickly. But I prefer to answer the questions, I think.
Okay, so there is a question about anticipation of aging because of COVID-19, so we can discuss it later, right, or not?
Yeah, I will cover that in the COVID talk.
Okay, let's see. Professor John, do you consider there is an overlap between malnutrition and physical frailty?
So the answer is yes. I mean, a part of physical frailty is weight loss. So when you look at malnutrition, it can be because you're not eating very much, and that can cause frailty, or it can be because you've got cachexia, which on the whole is due to an increase in cytokines. So all of these overlap. And I mean, I think that's part of what I'm trying to say. Often when I give this talk, I talk about the anorexia of aging, and I talk about cachexia. I talk about it together with the sarcopenia and the frailty, and then cognitive dysfunction. And in our rapid geriatric assessment that we've developed, or that's computerized, basically we look at all of these and put them together, because we realize that often when a person's getting into trouble when they're old, it's not that they have one thing, they have a little bit of 3, 4, 5 things, and you've got to pay attention to each of them if you want to get a good outcome. You can't just treat physical frailty and think you will fix things, and this includes looking at the environment, which is a big issue. A paper just recently came out showing that you are more likely to have cognitive dysfunction if you live in a place where there are loud noises. Why is this? It's because you can't hear properly, and people who can't hear properly get cognitive dysfunction. They also tend to fall more often, and they tend not to go outside and exercise. So it all comes together. So you could argue, if you're a good clinician sitting out there, that one of the things I didn't tell you to do is look in the ears and get wax out of the ears, and you may do more good doing that for physical frailty than anything else. And in fact, we did a study like that in the nursing home, and it not only did it improve cognitive dysfunction, but it did also improve physical frailty. So we have to pay attention to the multiple causes, and it's really, that's the message I would like you to go away with, is there's so many things going on as we get older, and we've got to treat each of them and try and slow things down by treating many things rather than just one.
Okay, one more question. I will ask 2 questions at the same time, and then we finished, okay?
Okay.
The first one, as a frail person has reduction in neuromuscular strength, maybe a loss in nicotinic receptors might happen. Do you know if there is a reduction in nicotinic transmission in central nervous system?
There is some. It doesn't apply to everybody. Remember, I showed the C-agrin slide specifically to point out it's about 30% to 40% of people who get physical frailty actually have a problem with their nerves. The others have other problems. So yes, there are changes in the nerves. Obviously, we see much of physical frailty in diabetics, and they have peripheral neuropathy, as well as a change in their central nervous system functions. So I think the answer is there are many things going on. We don't have good drugs to fix many of these things, and we don't quite know when and how to give them. So we know that we can improve function in the neuromuscular level by doing exercises. This is true somewhat in diabetics as well as in physically frail people. So I think we start with the simple things, the things that we don't do as health professionals. I mean, it's really my problem as I get much older and I start to look at what I should have been telling people. I had all these wonderful things I could tell them, but I often didn't push enough to get them to do exercise, to do something to keep their mind active. I was very good at getting wax out of the ears. It made a big difference. So I think we've got to recognize that the simple things are where we focus for the prevention of physical frailty. And if we do that, our outcomes are much, much better. Because once you get to disability, coming back from there is very difficult. And at that stage, your return to normal is not to normal. It's somewhere in between. So you get 6 months to a year better quality of life, but it's not as good as if I'd intervened 5 years earlier and stopped you getting to the disability stage.
Thank you. I think the next is the last one, unless I missed something, I don't know. So the question is about the possible relationship between the color of the skin and levels of vitamin D.
So if you've got a dark skin, the sun doesn't work as well at creating levels of vitamin D. God, being so much brighter than any of us, recognized this when he or she created humankind. And what they did is said, look, if I know that you're going to need protection from the sun, so you'll have a dark skin, but then I'm going to lower the binding protein for the vitamin D. So you don't need to have as much vitamin D because you will have more free vitamin D for a lower level of vitamin D. So that's what's going on. It's a very complex issue. For years, I didn't realize this, and I just assumed I measured vitamin D, and if it was low, I gave people vitamin D, and I didn't realize that some people who are high could be vitamin D deficient, and some people who were low were not vitamin D deficient. And we do know today that really you've got to be pretty vitamin D deficient to make a difference to your outcomes by replacing vitamin D. Most probably 10 nanogram per mil is the level of cutoff, not even the 20 that you use, but where you see in the literature 30s, 50s, and all sorts of things. This is a fantasy. It's created by scientists like me who decided we wanted to create something because it's fun, and they created something that was wrong. And there are lots of fallacies in the literature, and vitamin D fits into that area of, yes, it's important when your values are really low, but it depends very much on the amount of binding protein, what a very low level is. It's a complex area, and at least 80% of people who see old people or work in vitamin D, and the endocrinologist will tell you I'm talking total trash, because for years and years they've given everybody vitamin D. They believe they've solved everybody's problems, but if you go look at the literature, they didn't. So it's a complex area that's going to change over the next 10 to 20 years.
Okay, thank you very much. I think we do not have more questions. So,
quickly we'll go to COVID frailty, and I'll try and leave little time for questions. Okay. So frailty in the time of COVID-19. Well, you all know that out of Wuhan, COVID sort of escaped, and it escaped actually first to Northern California. They had a number of cases early in January. Nobody paid any attention to them. Then it developed in the Seattle area, Washington State. But in the meantime, and between those, in Milan and other parts of Italy, they got a different strain of COVID, which spread very quickly, and COVID became a real problem throughout the world. Basically, what makes COVID worse and what makes you more likely to get it? If you're older, if you have high blood pressure, diabetes, people who smoke, some evidence that there may be an increase in COVID in African Americans, though this may be related, at least in the United States, to socioeconomic status and not necessarily ethnic groups. The important thing, though, is there's a lot of studies showing that at least when you use the Rockwood approach of frailty, that little picture diagram you see there, frailty is very highly associated with COVID-19. So people who are frail and get COVID-19 have much poorer outcomes. So when you get COVID-19, you all know you start off with a cough, sore throat, dyspnea, chills, and hypoxia. You may get hepatitis. Some people will get a myocarditis and a myocardial infarction. You may get these funny looks of your toes and chilblains because of clots in the vascular system and deep vein thrombosis. You can have kidney injury. You get myalgia, muscle pain, muscle wasting with cachexia and sarcopenia. Some people get colitis and diabetes. A small subset find if they've got type 2 diabetes, they go to type 1 diabetes. And then a lot of people cannot smell, cannot taste, and develop anorexia. And in the central nervous system, you get delirium, encephalopathy, headache, falls, and stroke. We know that you get very sick when you have your cytokine storm with the increase in the inflammatory cytokines, IL-6, IL-1, and tumor necrosis factor. These are the people who finish up not being able to breathe, finish up on respiratory support. Lots of labs are abnormal, and I'm not going to go through those in any detail, except to point out that D-dimers often go up in people with COVID, and when they go up, it means that they're clotting and they should be on anticoagulation. So this is just showing you that the inflammatory cytokines are part of sarcopenia as well as cachexia, and we have to recognize that screening for sarcopenia as well as cachexia. And cachexia, I use the Glasgow Prognostic Score. This is weight loss, especially muscle, anorexia, low albumin, and an increased CRP is a good way to see if the person has cachexia versus sarcopenia, but we need to look at them both and pay attention for these things. We have to recognize that people who get COVID are difficult for the caregiver to use. They tend to often be confused, have delirium, fear, helplessness, anger, depression, and denial. Older people don't understand why they should be socially isolated, and this can cause all sorts of problems. The lack of social support. Where are my friends? Why can't I be with my family? Who will help me? And medications. And particularly in people who've got early dementia, this can accelerate the early dementia. I need to point out that you do not tie down people with delirium. The Australian Delirium meeting just finished today, and quite honestly, in the United States, and I think sometimes in Brazil, physicians and health professionals, when somebody is going crazy and they're old, they want to protect them by tying them down. When you tie them down, the first thing you do is you cause muscle loss. The second thing you do is you make them irritated. And basically, we know that we've still got people in Guantanamo Bay who we haven't been able to bring to trial for whatever they may or may not have done, because basically they were tied down and tortured. Tying down an old person is torture, and we need to recognize that. You have to sit with people. We've developed a delirium intensive care unit where we have a nurse's aide who sits in the room, and we have had no problems dealing with delirium under those circumstances. So getting rid of restraints is really important. Nursing home medicines have been a disaster with COVID. I'll use the Spanish Army, who found care home residents dead and abandoned when the staff walked out on them in Spain. But this has been a problem everywhere. Staff have been scared to go into nursing homes. There's been a decrease in the available people to look after people. And because we're trying to isolate people, this gets us into a lot of trouble. So we know that many people in nursing homes are positive. They've got all the things that basically can cause them to run into trouble. But a lot of them will have the symptoms that are atypical and won't have the diagnosis made, which we need to recognize. We have to be able to test both staff and patients regularly. We need good personal protective equipment. It's very important not to take people from hospital who haven't been tested. We had a disaster in one of our nursing homes where the hospital decided it had too many patients. So it convinced the nursing home to take a large number of patients, all of whom were untested, and about half of whom had COVID, who they then gave to everybody else. And the isolation is a problem. We have to find a way to look after people in nursing homes without major isolation. We've used some computer approaches. It helps, but we're not at the stage where most older people can cope with all of that. Social isolation. COVID has caused a loneliness epidemic. Our Surgeon General in the United States said, during my years caring for patients, the most common pathology I saw was not heart disease or diabetes, it was loneliness. Loneliness is often missed in older people, and it leads to depression, poor quality of life, poor sleep, worsening mentation, impaired function, cardiovascular disease, increased hospitalization, and increased mortality. So the message is nobody should be alone in old age, but it is often unavoidable. That's Ernest Hemingway saying that. But I think we need to recognize we need to try very hard to get visitors and volunteers into the nursing home in COVID times. But it's also people staying at home during lockdown. They've become very lonely. They are told to avoid people. But avoidance of people is going to cause lots of pathology. So we've got to look, and again, using where available computer approaches helps, but it's not quite the same. And we have to look more at how can we get people in contact with one another without spreading COVID. COVID has become one of the major causes of ageism. Many articles have said it should be thought of as the boomer remover, basically, which I think is pretty horrible. But we know that basically in Italy, hospitals use chronological age-based cutoffs to ration ventilators as a form of distributive justice and inappropriate. Many healthy younger adults initially ignored recommendations to socially isolate and protect their older relatives. This would be neglectful ageism. And then we have the weird governor in Texas who makes no sense to me whatsoever, who said that older people, including himself, would volunteer to die so Americans wouldn't lose our whole country. I'm not certain he's right about that, but certainly given everything else he's done with COVID, I think we could say he's wrong, and we could call that very hostile approach. And, and then we have to be careful to make sure we count old people as dying. Remember that before we say that old people can be removed, here I'm showing our previous president, but our present president in the United States is even older. So let's accept that you can choose what you wanted to do with our previous president, but the present one is a fairly functional person. The Dalai Lama basically is someone who is highly functional. Queen Elizabeth, well into her 90s, is basically a clearly great example of a highly functional older person who said, work is the rent you pay for the room you occupy on earth, and she's still working. And then the Pope is also an older gentleman. So I think we should recognize that older people are highly functional. I'll share with you that I'm 75 and I'm still, I think, functioning. You can make up your own mind at the end of this talk how well or not well I'm functioning. But realistically, all of us are functional individuals, and we should not use ageism as a reason not to treat COVID people. Perhaps the most important thing to recognize is the long COVID syndrome. This is where where symptoms last longer than 3 months after the acute event. It's present in anywhere between 5 to 45% of people. Most of it is gone within a year, but there's still people longer than a year. And this has been seen with other viral diseases. Infectious mononucleosis, for instance, is a classical example of what you get is equivalent of the long COVID. And its symptoms are slightly different from COVID. Fatigue and dysphoria, confusion or brain fog, some headaches, the anorexia, dysgeusia, anosmia tends to last. They may have red eyes, cough, shortness of breath. They tend to get postural orthostatic tachycardia syndrome and autonomic neuropathy, often associated with chest pain, kidney failure, joint pains, falls, myalgia, sarcopenia, and cachexia. And as you look at this, you'll realize that for my definition of physical frailty, almost all the things they're getting are part of physical frailty. When we look at the people with post-COVID, they have cardiopulmonary effects. The number of pulmonary emboli occur before and in the post-COVID period. Always check a D-dimer, and then basically the VQ scan is better than the CT to find these because most of the emboli are very peripheral and CT doesn't do as well at picking that up. Myocarditis, fairly common in some people following COVID. Rodriguez, the pitcher for the Boston Red Sox, is seen here, and he could not play in the abbreviated baseball season last year because he was so fatigued following his COVID, and he also had myocarditis. You can also get arrhythmias following COVID, and then the lung disease, you have lots of post-inflammatory lung damage. This means you should be looking in all people post-COVID at lung function tests. Breathlessness can be treated with breathing exercises, home pulse oximetry. You can try a methacholine challenge because some get the cough variant asthma, which is not obvious. And pulmonary rehabilitation is clearly an important piece that can be done in the post-COVID people. The anosmia and also the dysgeusia that occur can actually be treated with exposure to odorants or testants like rose, eucalyptus, lemon, cloves. This you need to do for about 16 weeks. And in the one study, they found significant improvement in smell in about 2/3 of the infections, post-infectious people. Fatigue is a big piece of the post-COVID syndrome. They have the sarcopenia, weight loss, dysphoria, depression, anxiety. They have trauma syndrome. They have sometimes sleep apnea, and the physical frailty is just a very common piece. How do you treat this? You use graded exercise. Graded exercise means that if the person's got POTS or autonomic neuropathy, you don't tell them to stand up and let them fall down all the time. If they develop a tachycardia, the exercise has to be very small. It has to be done in pieces. We have to think about it. Chair exercises may be important. Why am I spending so much time on this? Because I put this out on my Twitter account. And by the way, I've got a very active Twitter account that you are welcome to join on aging. But basically, one of the physical therapists told me, I can't tell these post-COVID people to do graded exercise because it's very bad for them because they may have some of these problems. And some of them get post-exercise fatigue. That doesn't mean you don't do the exercise. It means you do very small amounts of exercise and get there. Obviously, you'd use the leucine-enriched amino acids. They need support and psychological therapy. They may need referral to a psychiatrist for their depression. And they need nocturnal pulse ox to check and see if they've got sleep apnea and then CPAP. Then finally, they often have brain fog. You could use either the St. Louis University mental status exam, the SLUMS, or Montreal Cognitive Assessment to make the diagnosis. Mini mental status does not pick up the early kind. So brain stimulation games work. We've talked a little bit about cognitive stimulation therapy and exercise. They work really well. And then always look for depression and sleep apnea. Sleep apnea is one of the major causes of early dysfunction that is treatable and cognitive dysfunction. So please think about these. And then finally, can vaccine improve persistent symptoms for COVID long haulers? The literature is very incomplete, and the answer is most probably maybe. That's not a useful answer. But I would like to point out to you that we've now done a number of studies using the dementia, tetanus, the influenza, the Zostavax vaccines, and looking at epidemiological studies to see what their effects are on dementia and cognitive dysfunction. And it's clear if you get these vaccines when you're older, you decrease your chances of going on to get dementia by about a third. So a third of people who would normally have dementia are not getting them if they're getting their vaccines. We don't know yet whether COVID vaccine does the same thing, but clearly vaccinating people seems to improve, I think, regulatory T cells, and this is why you stop the ongoing dementia, which for almost everyone, whether it's Alzheimer's or vascular dementia, has an inflammatory process. And with that, I'm going to stop and answer any questions. I think I've left about 4 minutes to answer questions, so let me see if I can get out of this, slowly getting out of it.
Thank you, John. I think we don't have more questions in the chat, so I will ask you a final question. That's okay?
Okay.
It's not exactly a question, but I would like to know if you agree that more than ever, we have to put frailty in the screening for older persons, especially in the COVID times, and for the recovery persons, as well as preventing worsening of COVID-19. What do you think about including intrinsic capacity in the screening of older persons?
So, Sandra, you know me well enough. You know the answer to this is fairly straightforward. I believe before COVID, you have to screen for physical frailty. That's why we came up with the FAIL, a quick test. I believe you should screen for sarcopenia, SARC-F. I believe you should screen for anorexia of aging. That's the SNAC. And I believe that you should use the rapid cognitive screen that we've developed to screen for memory function. And then you should ask something about advanced directives. And that should be done once a year in every older person. It can be done by a health professional, but it needs to be done. And if it comes up positive, they need to look for and do the things that treat it. And it's overwhelmingly important that they do these things. So you asked me about screening for intrinsic capacity. I have no idea how you screen for intrinsic capacity. So this is my problem. Bruno Vellis and his group in Toulouse have a bot frail, which they say screens for intrinsic capacity. It actually screens for sickness and frailty. Intrinsic capacity is you're doing fine. There's nothing wrong with you. So what do? I do what the doctor does when I go to see them. They say to me, well, John, how are you doing? I say, oh, I'm fine. There's nothing wrong. I just came because it's my yearly visit. And basically they say, oh, well, that's fine. Let me check your blood pressure. Listen to your heart quickly. Put a stethoscope here. Listen to your lungs. Yeah, okay. And then they say, okay, well, that's quick. Now I can get you out quickly so I can spend time on the people I really need to. But the people we need to spend lots of time on are the people who are just fine. And those are the people who are frail. Those are the people who've got mild cognitive impairment. Those are the people who are starting off having anorexia and the people who are starting to lose muscle. And we have to pay attention to that because that is where you can treat. And preventive medicine in old age is even more important than it is in younger people. So my answer is simple. You should screen. We developed, as you know, the rapid geriatric assessment. That's the one that's computerized at the National University of Singapore, and they found it really useful to do on people. I think it should be done on every older person everywhere in the world. And you can use some other screening tests if you want, but ours has been shown now to work really well. We've looked at over 10,000 people in Missouri. We pick up lots of things, and most probably the number one thing we pick up is sleep apnea, because for reasons I don't understand, health professionals never think of sleep apnea in older people. Because I say I'm tired, they don't think of sleep apnea. It's not as if it's the first thing. So if you're fatigued, you have to have a test for sleep apnea. And if you've got sleep apnea, it's totally treatable. My favorite patient was a very famous financier who came to me, and he was told he should stop advising people because everybody who was advising was going bankrupt. So he came to me because he didn't want to stop doing this, and said, I must be sick because I am so good at what I do. It can't be a mistake. So I said, I was talking to him, and after about 3 seconds, he was falling off to sleep while he was talking to me. And I said to his wife, does he stop breathing at night? She said, oh, all the time. We put him on CPAP, and 6 months later, he comes back to see me, and he says, oh, I'm back seeing patients now, people now all the time. They all think I'm wonderful and marvelous. Thank you for curing me. And I said, well, now let's work on all the other things that are wrong with you as well. But realistically, it's such a fixable condition for both frailty and also for fixing people with cognitive dysfunction. So screening for sleep apnea, and I do a lot of screening, as you know, in the community. We go out and do these screening tests, and I always ask people, are you tired? Do you snore excessively? And has your partner ever told you that you stop breathing at night? And every time I go out screening, I pick up 10 to 20% of the population with sleep apnea. So that's, I think, what we should be doing. I'm most probably not right. I'm told by many geriatricians, this isn't our job. I say, look, our job is to get people to do the things that we should be doing so we don't have a job anymore. And I think I would be very happy if I could get there.
Okay, thank you very much.
It's just, if Ivan thinks that people should be screened, or they should be allowed to get so bad that they come to him.
Yeah, okay. John, thank you very much. I know you have to leave now. So the people in the audience is saying just thank you very much. Excellent talk. Thank you for sharing your time with us. And I hope you can meet as soon as possible.
So do I. And thank you very much for setting this up. It's really important to get the message out, and I know you do. You and Ivan both do a wonderful job at getting out the message in Brazil, and Brazil needs help just as America needs help. We do stupid things. We have politicians, so we do even more stupid things than physicians do. So good luck, and good luck to everybody there. Thank you all very much. Okay, bye.
Bye, John.
Thank you, John.
Bye. Well, okay. Ivan, we go on in English, right? Because of the people in the audience. Is that okay?
Okay, sure.
So, are you able to open your presentation now? Because my student is not with us anymore. He had some problems with the computer, so...
Mm-hmm. Yeah,
let's go.
Yeah, I'm trying to. Let's see. Wow. Okay, I'm trying to fix. Not so simple, but I'm not a tech guy.
Oh.
Let's see. Okay,
everything that you told to John.
Yeah, but as in life, it's easier to explain and teach than to do.
Yeah,
So,
yeah, I agree.
yeah, I'm trying to. It's
Let me see.
Yeah, it's tricky here. I asked him before, but he didn't.
I'm trying to talk with him by WhatsApp.
Let's see
Ok.
here.
Quando
Okay,
aparecer a apresentação embaixo, clica nela para ir para a tela.
I'm trying to here. Let's see. Wow. Okay. I'm just, following some information here.
Apareceu a tua apresentação?
I think no. I think I will fix it. Yeah, I'm just following the recommendations here.
Oh. Just a minute. I think Ivan had a problem because he went out to the meeting. So let's wait a minute. I think Ivan is having some troubles.
Hi.
Tudo bem, Ivan?
Yeah, I had to, skip a little bit to fix the problem. I think now we're on, I think. Yeah? Do you see my screen? Yeah. Sandra?
Acho que quando eu saio da tela, eu... Você está me ouvindo agora?
Yeah.
Ok. I will remove myself from the screen, and then I think you can open your presentation. Ivan, can you hear me?
Yeah.
Your presentation is open.
Okay. So can I move on? Do you see my slide?
That's my... It was my mistake, sorry. We can see you now, Ivan. You can go on. Yeah.
Okay. Yeah, that's okay. So first of all, thank you, Sandra, for the invitation. It's a pity that John had to leave early. It's a pleasure to be with him. He's a kind of mentor to me since the beginning when I was introduced to frailty science, and so it's great to be here. Sandra asked me to talk about a little bit about the evidence of the association between brain and frailty. And I'm going to stick to try to my interpretation of the current evidence in a high level of evidence-based studies. And first of all, I want to remember you all that in 2020, a report for Gil Livingston published in The Lancet on dementia prevention, intervention, and care identified that we have at least 12 major risk factors, very modifiable, very reversible, that if we try to reverse them, 40% of incident dementia could be prevented. So this is a huge amount of prevention in dementia. It's much more than any drug designed until today. And of course, there's an association between frailty and cognition since the beginning. Just late after the couple of early years after the definitions of operationalization of the frailty, and this there is evidence that potential reversibility of frailty phenotypes, both the physical frailty and the multidimensional frailty definitions, that if we reverse then, this reversibility might be very, very important for prevention of dementia. So current evidence points to a frailty as a potential modifiable risk factor for dementia. I think this is the most emblematic evidence from the current literature that drives our talk today about the evidence, current evidence between the association of brain and frailty. So what I'm going to move on today, we're going to dive into today in this talk is the current evidence of brain and frailty association. I'm going to stick mostly up on a meta-analysis, high-level meta-analysis, and large cohort studies. And of course, I'm going to focus my research evidence on brain disease and conditions and frailty that are most emblematic, that covers the most high level of evidence in current literature. And this is, I'm going to focus on cognitive frailty and cognitive impairment. When I say cognitive impairment here today, it's a broad definition. I'm going to cover a mild cognitive impairment, cognitive disorders of broader sense, and I'm going to cover dementia, all dementia and Alzheimer's disease and vascular dementia mostly. And finally, I'm going to comment our current evidence on depression as we move towards a broad definition of like a lumped in psychiatry and neurology into a new discipline called neuropsychiatry. So depression is very, very important in late life. And when we say we have to look at the brain, we have to look at psychiatry disorders, and depression is one of the most, if not the one most important disorders in late life. So moving from the blood to the brain, let's see the theory regarding frailty leading to cognitive disorders. This is a model. It's my view of the things. There is a bidirectional relation between frailty and cognitive disorders, both dementia and cognitive impairment. This bidirectional relationship mostly relies on both pathophysiological concepts like social isolation, inflammation, hormonal pathways, poor vascular health, but also both shared risk factors like age, multimorbidity, disability, and cardiovascular risk factors like hypertension, diabetes, smoking, obesity. We have here depression that could be a moderator mediator factor between frailty and cognitive disorders. Also, sedentarism and low socioeconomic background. So we have a lot of things here that are common to both disorders, and we have a current evidence of both bidirectional relation between them. But it's most easy to understand, most emblematic, that we think about dementia, especially dementia. This is a more severe cognitive impairment. Dementia going to frailty is quite a natural. I'm a clinician, and as a health professional, I see this every other day. So when someone with dementia comes to the clinic, and I just follow up this person for a couple of years, 1, 2, 3, 4 years, this person becomes frail. And this is quite natural, because when the brain shrinks, we lose motor function, and we lose our drive to eat, and easily we lose weight, and we become sedentary, because there's no reason to go out of my house and do some jogging or walking. Why I should do this? Because I don't have cognition anymore to tell me that I have to do it. So this is a natural path from dementia to frailty. But I think most emblematic and most interesting, that frailty is potentially reversible. At least 40% of people with frailty are reversible, potentially reversible. So if we could better understand the relation from frailty to dementia, we could save a lot of people. At least if we can imagine that we can reduce disability, this would be a major outcome. So let's move to the evidence. I think I'm talking too much. So I'm going to first show our recent meta-analysis about this relation, about frailty as a predictor for cognitive disorders. We did a systematic meta-analysis, a systematic review, and meta-analysis a couple of years ago. And unfortunately, we find just 6 studies. So this is not clear-cut. The evidence, I think, it's developing more than a very high level or solid evidence. And what we found? We found that the association is strong. It's 1.8, 80% the odds ratio for cognitive disorders. Look at the term. Cognitive disorders is an umbrella on dementia and also mild cognitive impairment. So this I'm just sharing the evidence between frailty as a broad predictor for cognitive disorders. And I have to address that there was a high heterogeneous between the studies here, almost 80%. So we have probably some bias in common methodological issues between these studies. So this is initial evidence. And when we look at these studies, most of them use the physical frailty phenotype definition for frailty. And when we think about the physical phenotype, we know that sarcopenia is a big risk factor and a major development factor for frailty syndrome as a geriatric syndrome. And we decided to look at the association of sarcopenia and cognitive impairment in older adults, and we did a systematic review and meta-analysis. I know that I just saw her, Gabi Sipol is in the audience, so she can comment. And what we saw is a very significant relationship between sarcopenia and cognitive impairment. 2.5, it's a high association, but again, we had a lot of heterogeneity between the studies. And another major issue here is that all of these studies are cross-sectional. So there is no causality here. We have to drive our attention regarding or towards causality, and there is no causality here. There's a cross-sectional association. So we have some doubts. And in the same year, I think the group of Laura Fatriglioni from Sweden, from Karolinska Institute, they are much more clever than myself and my fellows. They ask the same thing. Well, how about the relation between frailty and cognitive impairment? But they just share the evidence between 3 groups. How about we see the frail guys, the cognitive impaired people, and the co-occurrence, the simultaneous occurrence of frailty and cognitive impairment. And let's see what they found. Well, they just select the same studies that we selected, so that's okay. It's temporally speaking, it's the same selection of the systematic review. But the most interesting here is that we can see that they analyze isolated cognitive impairment. They look at isolated frailty, and they look at the two together, the co-occurrence of the two disorders. And what they found, this is very exciting. They found that the people with cognitive impairment, they had a high risk for incident dementia, but there was no significant increment in the risk when we look only frailty, okay? And when we look both together, the co-occurrence of the both, we have a higher risk, a little bit higher risk when we look at the two together. So this is quite amazing because frailty here appears to be like a moderator in this relation, or maybe a mediator factor in the relation of cognitive impairment and the worst outcome called dementia. Okay, well, most of the studies had some methodological issues that which are quite debatable, because they didn't look at the hierarchical relationship between the occurrence of frailty and the occurrence of cognitive impairment in temporal relation. That's the discussion of the egg and the chicken, who's come first. And this is quite important beyond philosophical concerns. But if we think about what's the most important factor that drives someone to dementia, it's quite important to ask about who's come first. And then I have to look up this study of my good friend Chun-Li Xu from Johns Hopkins. This is a very interesting study, just published in the same year, 2019. Xu and his colleagues, they look at more than 3,800 community-dwelling participants of the National Health and Aging Trends Study. It's a US-based population. It's a very nice, very well-designed study. And these people were followed up for 5 years. And the current object of this cohort study was to identify correlates of frailty onset before cognitive impairment. They also look at cognitive impairment onset before frailty and the co-occurrence of both. So this is quite a beautiful study. Well, 6% of the sample neither showed frailty or cognitive impairment. Okay, let's look at the 40% remaining. So frailty came first in almost 80% of the sample. Okay, and how about incident dementia? When we look at the sub-hazard ratio, and we have to address mortality as a competing event here, we were very surprised to see that dementia was just reduced when frailty comes first. Okay, this is quite interesting. When we look to another outcome, multimorbidity, we're just not well surprised. When we have frailty, the risk for developing multimorbidity was quite high. Well, when we look at the people that develop cognitive impairment first, almost 25%, almost 1/4 of the sample, incident dementia showed a sub-hazard rate of 2.6. Well, very significant, very high, short confidence interval. So this is a big significant finding here. And when we lastly look to the co-occurrence of both frailty and cognitive impairment, 6% of the sample. And how about incident dementia? 80.7. Look at this, 2.6 to 80.7. How about frailty plus cognitive impairment? Very important. As John just talked, when we look at a frail person, just chase cognitive impairment. They are very commonly associated. And now we have a cohort study, a prospective, very well designed cohort study that shows that frailty may be a catalyzer, maybe a moderator at least of the hazard ratio of dementia. And this is very, very interesting. And the same group, Chen Shu, just published it the next year. Another question about this cohort. This is the same people. And they asked about associated factors. Frail people appears to be different from those with only cognitive impairment and those with the co-occurrence of frailty and cognitive impairment. How about different risk factors or different associated factors at least? And what they saw it that the highest prevalence of obesity, current smoking, comorbidity, among others interesting factors, were very prevalent in frailty people. That was quite different from people that had only cognitive impairment. Those people had anxiety, depression, hospitalization, dysfunction in areas, and mobility tasks, and stroke, diabetes, and among other factors. And those people were different from those that had co-occurrence of frailty and cognitive impairment. This latter group is quite sick. They had the highest prevalence of dementia, depression, cardiovascular disease, and disability. This is, of course, we're hoping to see this, but the most interesting factor here is that the frailty people had different risk factors or associated factors at the best from those that had cognitive impairment. This is quite interesting finding. So a couple of years ago, we look into this evidence. We ask ourselves about the concept of mild cognitive impairment. This is a very important concept when we saw it as a quite important risk factor for developing dementia. And we looked to it in a systematic review, and we just couldn't meta-analyze the data because the data was not so good. But we did a qualitative systematic review, and we just saw an insufficient evidence supporting the association between the concept of mild cognitive impairment and frailty. When we look at these two prospective longitudinal studies here with a variable sample here, and using the physical frailty concept to identify frailty and different concepts to identify MCI, we have a positive association that at least 50% of people with MCI were frail. Okay, so it's a huge prevalence, and this drove us at the time to look at our small sample at our outpatient at that time. I was in another research group, and we had interesting data regarding CSF biomarkers for Alzheimer's disease among those people with amnestic mild cognitive impairment. And we had also CSF biomarkers for healthy cognitive people. So we just drove our attention to these people, 66 outpatients, 40 with MCI, and 26 normal controls. And we applied two different concepts or criteria for frailty. We used the physical frail phenotype, but we also used the Edmonton frail scale. And why was that? Because the Edmonton takes cognitive impairment into the equation to say that that person is frail. And our first hypothesis is that as Linda Fried in her seminal paper describing the physical frailty phenotype, she just excluded those using antidepressants, those with severe depression, those with stroke, those with cognitive impairment. So in the inception of the concept of physical frailty, those people were not included. So we decided to check if we use another kind of criteria to identify frailty, if we would have a different finding. And as expected, but with a low sample size, we have a positive difference here in the table in our left. We have a different sample among pre-frail and frail people. When we look at the Edmonton Frail Scale, of course, they had a cognitive variable or cognitive component in the scale. Of course, it's expected that they will be different. And when we look to the physical frail, no difference. Okay, when we stratify all the 66 patients, MCI and health cognitive controls, no difference regarding frailty status. And most surprisingly, we did a very broad neuropsychology battery that covers attention, memory, executive function, visual spatial function, and the total score. And when we look to the Z scores here, and both of this box here on your right, and we look at the CHS, the physical frail definition, and we look to the Edmonton frail definition, no difference, no difference. So when we stratify frailty among these people with MCI and normal cognition, no difference. So the frailty concept didn't show any kind of difference in cognitive function. Well, we move forward and we asked about, well, there is a concept of cognitive frailty, and both variables must be very interacted. And we run an interaction analysis, and we just was surprised with this data in table 3 here. They did not interact. So it appears that the cognition follow one path and the frailty follow another path, and probably they will interact longitudinally, but cross-sectionally, they were different variables, independent variables. And moving forward, we just asked about, well, if we have the physical frailty phenotype as a concept that excluded any kind of cognitive component, how about we look to the association of cognitive variables with the physical frailty variable? And we were just surprised to see that visual spatial function were significantly associated with physical frailty. We're just expected as we look to amnestic MCI patients, we of course were hoping to memory function or at least executive function to be associated with the concept of physical frailty. And for our surprise, we did find an association with visual spatial function, a non-AMCI profile, non-amnestic. That's really interesting because we tend to consider the physical frailty more associated with Alzheimer's disease due to both concepts are quite neurodegeneration along with aging, and frailty is a geriatric disorder that progresses with aging. So both are concepts that are highly correlated with aging, and we have this surprise. Well, let's move forward to a higher level evidence, and I think we are going to have another surprise here. So the group of Kenneth Rockwood from the Halsey, Canada, they just published this year a very interesting paper. They just asked the same that we asked in 2017, well, of course, with a huge sample, a US sample of more than 3,000 people between 65 and 99 years with a variable follow-up. The last was 14 years. They identify almost 2,000 people with MCI, with dementia follow-up, so a large sample, and a high-risk sample, almost 50%. And they used the frailty index concept to identify frailty, and they asked about, let's see the association of frailty with MCI in a broader sense, and let's see the subgroups, the amnestic MCI and the non-amnestic MCI, and what are the level of association. And they found positive relations to a broad concept of MCI, but to both AMCI and non-amnestic MCI. But most interestingly, when they excluded all potential overlapped risk factors for dementia from the frailty index, they did a sensitivity analysis, and they reduced their frailty index for 45 items to a 16-item frailty index, just total exclusion of potential risk factors for dementia. And when they asked about the risk for dementia that could be mediated by frailty in the sample with MCI, surprisingly, they just identified that non-amnestic MCI kept a significant relationship with incident dementia. So what's the message here? Frailty is a multidimensional concept following the frailty index model, identified non-amnestic MCI people with a higher association for incident dementia. Okay? Remember that non-amnestic MCI, they are not so much as related to Alzheimer's disease. They are more associated to vascular dementia, to frontotemporal degeneration with Lewy body dementia. So non-Alzheimer's dementia mostly. So we have to keep this on track. So what are our conclusions at the first topic here? So the question I ask you is, frailty predicts cognitive decline? Well, how about the evidence of this association? Well, they are highly associated for sure. Both are present before incident dementia is observed, so they are both risk factors. But frailty may potentialize the burden of dementia, like a mediator or moderator factor, depending on the design of your study. And there is, of course, a lack of good evidence regarding MCI subtypes, but the current literature tends to see that non-amnestic MCI types are more associated with frailty. So frailty is much more associated to non-Alzheimer's pathology according to MCI subtypes. Okay, well, let's move forward to the relationship between frailty and dementia. Okay, so we are going to now look to direct relationship between frailty and dementia. So we are going to move from a broad concept of cognitive impairment to a more strict concept of dementia. And we have to first talk about this meta-analysis from the group of Kate Walters from the University College London. They really asked about this. Frailty is a predictor for Alzheimer's disease, vascular dementia, and all-cause dementia in community-dwelling older adults. So they performed a systematic review that identified only 4 studies for meta-analysis. Again, I remember that I think this is a constructing concept, much more than a very solid concept. So we have to think about this. We talked about cognition and frailty, and cognitive frailty is clear-cut concept. I don't see much of this. So it's a constructing concept, and this is the qualified table that shows every study here. And we have to look at the frailty criteria that was meta-analyzed here. So the studies that enter the meta-analysis or the quantitative analysis of the systematic review, 100% regarded the physical frailty criteria. So I'm going to talk about the association of the physical frailty and dementia. So what they found? Well, they stated in the paper, if you read the paper, they stated that there was an association between frailty, that's the figure 1 here, and Alzheimer's disease. And I simply don't agree. I don't agree with them because the confidence interval here, covers 1. We have 1.28, 28% plus the risk for Alzheimer's disease among frail older adults, but I can't agree. At least this is a trend for me. It's not a high-level evidence of the association between frailty and Alzheimer's disease. We have a marginal significant value of 0.05. Well, and how about pre-frail people? Well, worse. They did not show evidence of the association between pre-frail and Alzheimer's dementia. And how about vascular dementia? This is figure letter B here. We had only 2 studies, Solfridi from Italy and Avila Funes from France here, and they had a positive, very significant association of 2.7, the hazard ratio here, between frailty and vascular dementia. So a very positive relationship between frailty and vascular dementia. If we move backward, when we just talk about cognitive impairment, we had some evidence towards non-amnestic MCI, which is mostly associated with vascular dementia as an outcome. And then now we see that there's a strong relationship between frailty and vascular dementia. Well, at last, they just look at the relationship of all-cause dementia, and they had a positive relationship between frailty and all-cause dementia, mostly drove by Avila Funes and Solfridi cohort studies that look at vascular dementia. Well, there's another interesting factor in this meta-analysis that they did a meta-regression analysis. So they looked to potentially associated factors like sex, age, and other factors that could drive the association between frailty and all-cause dementia, Alzheimer's dementia, vascular dementia. And what they found is that female sex was significantly associated with Alzheimer's dementia. So we know that female sex is associated with frailty more than male sex, and we know that female sex is more associated with Alzheimer's dementia. So it's kind of a natural drive that we could find that the female sex have some significancy in the association between frailty and Alzheimer's dementia. But it's a positive finding here. Well, so we have a positive association between frailty and vascular dementia. So frailty is associated with dementia. But how about neuropathology? Oh, this is a very interesting study published this year from the group of Kenneth Rockwood from Canada. And they look at a neuropathology bank from the Cambridge City over 75 cohort study. So they analyze people that died and donate their brain for neuropathology analysis. And this is a very interesting study because they construct a frailty index, and they also construct a neuropathology index to look at the potential interaction and a potential association between frailty as a multidimensional criteria using the frailty index and neuropathology in the brain of those people that died with dementia diagnosed and those people that died with normal controls, normal cognition, okay? So people were identified as normal controls or normal cognitive functioning people, and they look at the brain of these people too. And what did they found? They found again, like our study in 2017, there was no interaction between frailty and neuropathology, as each concept was quite independent as risk factors for dementia. They identified that frailty index showed in autoradio of 33% more association with dementia. They observed a similar 39% plus association with dementia from a neuropathological perspective. And when both were together, they did not interact, and they just kept their association. The power of the association was just kept. So confirming that each variable is quite independent. So we have to look at someone with frailty and cognitive impairment as two independent variables that are risk factors for dementia. Most interesting that when we added the frailty index to the neuropathological index model, we improved the modeling of the regression equation. So this shows that frailty has a moderator hole here. So when we have someone with cognitive impairment and you add frailty, so these people have a higher risk for dementia. And what was tricky here, and this group moved forward in the evidence, but they were tricked by the fact that we have almost 26% of people here that we can see the orange bars here. These people had normal cognition and different forms of neuropathology burden. Even in high neuropathology burden here in our right, we see normal cognitive people here. So why those people died with dementia? Why they evolved to dementia if they had a neuropathology burden, and why another people had the same high neuropathology burden, but they didn't have any kind of dementia. So they put the frailty index in this equation, and in a modeling perspective, they found that 14%, almost 15% of these people here had dementia due to frailty. So if we could revert frailty, we could, save almost 15% of people with dementia. So this is a quite interesting study. And this group just moved forward looking to Alzheimer's disease biomarkers. They did a scoping review with that concept in mind. Well, let's see the neuropathology of the most prevalent dementia. And unfortunately, they had just a few prospective studies in the red circles here, and quite heterogeneous finding here. When we look to the findings, that they have mostly hippocampal atrophy associated with frailty, and they have neuropathological findings of neuritic plaques and neural tangles associated with frailty. But we have to move to a high level of evidence. And the same group of Ken Rockwood then published this, for me, is seminal paper, very nice paper that investigated the moderator role of frailty in the relationship between neuropathology and Alzheimer's dementia. They used the Rush Memory and Energy Project cohort of brain autopsies. So they look at a large sample of neuropathological burden of AD disease, and they construct a frailty index to compare the association between frailty in 3 different levels with 3 different levels of neuropathological burden, as you can see here, almost 500 people. And what did they find? Well, this is quite interesting. When we look at the y-axis here, we see the frailty index. When we go up, the worse the patient is, the more frailty. And we look at the x-axis here is the odds ratio for Alzheimer's disease pathology. So look at this interesting finding. Those who had a higher association with Alzheimer's disease pathology had a lower frailty index. When we move to a higher frailty level here, the association goes to the left. Well, how can we interpret this? Well, frailty clears moderate the relationship between dementia and Alzheimer's disease pathology. So if we have Alzheimer's disease pathology in our brain, but we have a high burden of frailty, this high burden of frailty is more important for the development of dementia. So if we have, for example, a great burden of neuropathology of Alzheimer's disease in our brain in a low level of frailty, this will dominate my brain to develop dementia. But if we have a high burden of frailty, the neuropathology itself is not so much important. So this clearly confirms this moderator role of frailty to dementia. And finally, I think the best study that looked to physical frailty model and dementia incidence came from data from the UK Biobank. It's a very large biobank. It's more than 500,000 people from UK. And this particular study evaluated 143,000 people included in this analysis. The first question was very simple and direct. They asked about the relationship and the association, the hazard ratio between frailty and dementia, and pre-frailty and dementia. And what we have here, we observed that in several modeling, we have a positive finding, almost twofold increase of incident dementia among frail older people. And when we look at the etiology of dementia, we had a positive finding for vascular dementia. Again, we did not have a positive finding with Alzheimer's dementia. They look at it, but we have a positive relationship with vascular dementia, 1.70, the hazard ratio, for pre-frailty, and 3-fold increase, a 3.0 hazard ratio for frailty. So a positive relationship between frailty and vascular dementia. They also asked about the components of the physical frailty phenotype. And most interesting, they saw that low grip strength here in our left, low grip strength independently predicted 80.84% of people with dementia. Well, if we could reverse low grip strength, maybe we could reverse sarcopenia with exercise and protein and calorie. We could delay almost 10% of people with dementia. Another interesting factor here is that people with slow gait speed, those mostly related in the literature with the cognitive frailty concept, well, they developed dementia 2.3 years before those that were walking as normal. So people that had a slow gait, they had early dementia, a little bit more than 2 years, and this is highly significant finding. Well, what are our conclusions of the association between frailty and dementia prediction? Well, when we look at the evidence of dementia prediction, we have that there's an associated all-cause dementia risk for those with frailty. We learned that low grip strength is a good predictor that we could look carefully in our clinical practice. Also, we saw that those people with slow gait speed, they develop dementia in a short notice. When we look back to the evidence for which type of dementia is more associated with frailty, well, there's no strong evidence-based association with Alzheimer's disease. Maybe some trend to women, we don't know. But we have a low evidence for AD biomarkers for sure. And we have to be careful in this conclusion because we had frailty as a moderating factor in Alzheimer's disease patient with a very positive neuropathology. So there's an indirect association between Alzheimer's dementia and frailty, and probably involving neuropathology of Alzheimer's disease. And finally, we have a strong association with vascular dementia in a clinical perspective. So, well, finally, we have all these associations between cognitive impairment and frailty. So some time ago, people put both together in a concept called cognitive frailty. John Morley just talked about this. And this is the consensus panel published in 2013. And what they define is that cognitive frailty could be reliable a definition that takes up on a patient with physically frailty plus a cognitive impairment, mild cognitive impairment, which is equivalent to a CDR, clinical dementia rating of 0.5, which is the same concept of MCI, mild cognitive impairment. And how about the evidence for this in frailty science? Well, mostly the evidence rely upon adverse outcomes, and we don't have validation in terms of internal validation constructs. So we are basically, we validated the construct of cognitive frailty as a predictor for adverse outcomes among older adults. As we can see in this meta-analysis published this year by the group of Shu and colleagues, they included 12 studies here. And what did they ask here? Well, cognitive frailty is associated to death, well, premature mortality. They also asked about the association between cognitive frailty and the development of dementia. Well, let's see here. So regarding death, higher mortality burden, yes, we have a positive association in the concept of cognitive frailty. We can see a positive trend here, a significant trend of almost twofold increase in death among people with cognitive frailty. Most interesting, they analyze not only frail people, but pre-frail people that we could call like cognitive pre-frailty concept. And these people also had a positive association with death. Well, they also did an elegant analysis here that they try to see if the concept changed when they move from different instruments and criteria, both for frailty and cognitive impairment. So they analyzed different instruments like the Mini-Mental, the HRS, and the frailty index, the physical phenotype, a modified version of the physical phenotype, and the Chiron criteria for cognitive frailty, and independent law of the criteria used to frailty or cognitive impairment, they kept a very similar hazard ratio here, 1.93. And finally, how about all-cause dementia? So some of the studies, fewer studies, showed a positive association. And here in this meta-analysis, we can see here a hazard ratio of 3.66. And what is available for me here is the heterogeneity here about 0%. So no probably bias in the sample mixed up here in this meta-analysis. So something around 3 times the risk for developing dementia, in a broader sense. So what are our conclusions before we move to depression and frailty relationship? And John and Sandra gave me 10 minutes more here. Hope you don't mind. And our conclusions here is, well, how about the concept of cognitive frailty? Well, for me, the evidence is weak for internal consistency of this as a singular construct. I think mostly the cognitive screening tests were used to base the cognitive variable of cognitive frailty. So this is not good enough for me. We have just up to now a few cohorts, mostly in developed countries. So we have another problem in the lack of temporal relations between the development of cognitive impairment and frailty. We should look to a co-occurrence to define cognitive frailty, and we did not have this. And finally, the evidence for prediction, incident dementia and mortality. Well, the crude evidence is good by this very recent meta-analysis, and there's a higher risk for incident dementia and mortality. So in this regard, I think we can conclude that motor and cognitive performances appear to share a common preferential trajectory in terms of their underlying central and peripheral neural control mechanisms. And their association is probably related to a neuroanatomical change that we can see in these patients. And additionally, alteration in specific areas of the brain, such as the primary and the supplementary motor cortices, as well as the substantia nigra and the striatum in a very particular sense, are related to a physical frailty phenotype, at least. But other potential mechanisms should include a decreased energy production and metabolic issues that is mostly regarded as a pathophysiological pillar or construct in frailty science to connect to the concept of cognitive impairment. So we're going to move to the last topic here and talk about the relationship between frailty and depression. So the first question here is what's the role of biological aging and geriatric syndromes in depression? So a few questions here that I can make with you all is, well, the connection between the two is something about excessive aging. Frailty could be a prognostic marker in depression. Frailty among depressed older adults could be a subtype, or simply frailty and depression is just overlapped constructs, as John Morley just answered a question before me here. So we can look at this slide. The slide is originally from Richard Odvoshar. It's a very clever slide that we can see somehow frailty and depression like two sides of the same coin. Why? Because we have similar or common determinants like weight loss, fatigue, slowness between frailty and depression. So we have common components here. And for sure, we have common consequence or common adverse consequence or outcomes. And how about the most reliable evidence that will come from two meta-analyses? Well, the first meta-analysis select a little bit more than 1,000 people in 24 studies, and they look this relation between frailty and depression. The prevalence of depression was almost 40%, somehow equivalent to the prevalence of frailty. And how about the incidence of depression among frail older people? Almost two times. And how about the prevalence of the incidence, of frailty among depressed older seniors? Almost four times here. So there's a bi-directional relation for sure between frailty and depression. But, well, it's just this. It's a bi-direction and nothing more. Well, when we look to the other meta-analysis, when we look to the risk for frailty in the depression group, we see something similar. 3 times odds ratio for developing frailty among depressed older people. And when we look at the meta-regression analysis, differently from cognitive impairment, most men are more associated with the development of frailty among depressed people. So male sex is a risk factor here, identifying the meta-regression of this meta-analysis, differently from the female sex that we saw in the meta-analysis between cognitive impairment or dementia and frailty. Well, we look at our cohort. It's in a real evidence, real world evidence here, using the frail scale or the questionnaire as the frail concept here, and we look more than 800 patients here, and we asked about, well, after 1 year of follow-up, how about the risk of developing frailty among depressed older adults? Well, surprisingly, we had a positive finding, both in the depression plus and antidepressant therapy here. They use SSRI monotherapy, but we also had frailty in those people that were remitted from depression. They had depression at least 6 months previously, but they were using medication for keeping them remitted. And this group also had a higher chance of developing frailty. So this is an unadjusted model, and we just kept the adjusted model, those depressed older fellows with antidepressant use. Well, we not use the frailty concept, but we start to look at a multidimensional concept of frailty, and we use it in another cohort study. This data is from Jundiaí Medical School. It's the MIMICS trial, in a cross-sectional analysis. When we used the frailty index concept, we just saw that major depression was associated with the frailty, but also those people with subthreshold depression, what we call in DSM-4 concept, minor depression. So even when we have minor depression, we have a higher chance to develop frailty. And this was highly adjusted for multiple interesting competing variables here. And how about when we see this patient longitudinally? So after 12 years, we look at these people again, and we have 2 to 4-fold increase in the risk of incident frailty. What's the importance of the MIMICS frail findings? The importance is that much of the evidence that came from those two meta-analyses involved people that didn't have major depression. They had a positivity finding from screening depression scales, like the geriatric depression scale, the PHK-9, the SALS scale, but they didn't have a strong diagnosed concept of depression. In here, people did a SCID-5, so a strong, reliable diagnosis of depression, and people had consultancy with two geropsychiatric specialists. So this evolved to a better and stronger diagnosis of depression. So major depression and minor depression appear to be associated with frailty in a very clinical concept like the frail, and a multidimensional dimensional concept of the frailty index. Well, we just recently we tested this relationship using data from the Lifelines cohort study. The Lifelines cohort study is a multidisciplinary, unique, prospective, three-generation design populational cohort study in the north of the Netherlands. And so this work comes from our group from the Groningen University in the Netherlands. And this work here look at more than 90,000 people with a 5-year follow-up. So we tested frailty as a bidirectional concept with both depression and anxiety disorder in the Lifelines cohort study. And this paper here is being submitted to JAMA Psychiatry. It's a very high impact factor journal. So we asked several questions to test the bidirectional association between frailty and affective disorders. And a new onset affective disorders is significantly associated using a frailty index concept to the development of both depression and anxiety. So frailty increases the risk of affective disorders, and also frailty contributes to persistency of those affective disorders in both younger adults, those with 40 years old to 60 years old, and older adults, 60 years or more. And here you can see that the odds ratio here is something between 6% to 13% more risk. Well, and how about the opposite direction? How about depression going towards frailty after 5 years? Well, we used another similar model. We used a 35 item frailty index, and what we saw that the development of depression is both significantly associated with frailty in both younger and the older groups. And how about the lifetime association with frailty? And we asked about not only the lifetime, but we asked about the remitted depression and anxiety, the new onset of any depression and anxiety, and the persistency of any depression and anxiety. And what we saw is that the older group just lost significancy for remitted depression. So why was that? Well, I think one of the explanations is the concept of resilience, as John Morley already told you all. And the other concept is reserve. And this could protect older adults for the development of frailty when they had depression in the late life. But most interesting, this was not protective in younger counterparts, that people with 40 years to 60 years, they still had the chance to develop frailty. And this calls our attention for preventive measures early on. So we have to look at those with 50 years old, because maybe when we have those with 70 years, we can make the same prevention when they got depression early on life. When they are 70 years old, maybe we can have the same benefit when we revert frailty. So another question that we drove last year is the prognostic effect of depression in frailty, among depressed older adults. And we did this outcome latent profile analysis in the NISDA study. It's a cohort of major and persistent depressed older adults from the north of the Netherlands. And what we saw, that we couldn't identify different phenotypes of depression here. And I want to call your attention that the last two phenotypes were those with frailty and depression, and those with frailty and depression and cognitive impairment. So we have two different types of depressed older adults. And what was the outcome here? Well, the outcome is that when we have frailty, depression, and cognitive impairment, these people are quite refractory to antidepressant therapy. They simply evolve as no remission. Okay, so after 2 years of follow-up, most of these people didn't remit. And how about death? Do we have something predictive for frailty among depressed older adults? Yeah, we have. We have two studies. One came from Australia, from Osvaldo Almeida. It's a good friend from Perth. And we have that, depressed older adults die more than their controls after a long follow-up. But when we look at the frailty component inside those with depression, the mortality risks goes from 4.26 to 1.79. What we can see here is a moderator effect of frailty, clearly a moderator effect here. So if you don't have frailty, you could die even more. Well, what's the importance of frailty? Well, frailty is quite important. It can modulate the risk of dying. But this was based on the frail and based on a less strict definition. And we look at the mortality excess for depression and anxiety among just younger and older adults. And what we saw is that when we count for frailty, the mortality among older adults here in the top, in the bottom of this table, we just lost significance. Okay, so frailty do not appear to highly influence mortality among depressed older people, but of course it is a player, is a moderator, but not the big issue here. Well, what's the big issue when we think that we could die more when we have depression? Well, this study we just published in the Journal of Clinical Psychiatry was online last year, now published officially early on this year. And we just used the data from the NISDA cohort study from the north of the Netherlands. And we look at that, frail, depressed older adults died more, 2.3 times the hazard ratio here. When we compare with non-frail depressed people, but we identified several inflammatory markers like CRP, interleukin-6, and GAL2 that were mostly significantly associated with the risk for dying here. We identify a protection hole of vitamin D. So if we have a high level of vitamin D, we have a protection against mortality. And if you have a telomere length strength, we had a higher level of mortality. If your telomere length was quite normal, you died less. So we decided to put all this together, frailty plus the inflammatory markers, plus vitamin D, plus telomere length. And what we found is that the frailty just lost significancy. So in terms of biomarkers, in terms of a pathophysiology explanation, frailty by itself, by its concept, and here is a physical concept of frailty, and the lifelines was accumulate deficit or frailty index concept, different concepts, same finding. So when we think about frail older adults with depression, pathophysiological findings like inflammation, telomere length, vitamin D, maybe oxidative damage, DNA damage are much important for dying than the frailty concept itself. Well, what are our conclusions? And just finishing here. Well, frailty and depression are independent constructs. Well, if we look at the evidence for an overlapped construct, well, the overlapped construct is weak, is mostly based on a population sample using screening scales for detecting depression. This is not accurate. We have a few well-designed cohorts with a large samples like the lifelines, and the problem that we mostly lack temporal relationship between the incident of depression, the incident of frailty, along with the follow-up. And how about the evidence for prediction? Sorry, it's just mortality, not dementia. And well, the evidence is good, and we have a good evidence for mortality as a moderator, but not an independent player here. So what we have learned today, well, when we see the association between cognitive impairment and frailty, frailty appears to moderate and mediate cognitive outcomes. Frailty is more associated to vascular burden than to Alzheimer's disease. The definition of cognitive frailty is frail, okay, a little joke, and requires more validation. And the cognitive impaired plus frail older adults show higher mortality for sure. When we look to depression and frailty, well, the two competitive definitions not always overlap. Some overlap, sometimes no. They sometimes are just competitive, independent conditions. So the frail, depressed seniors are a subtype of depression for sure, with worse outcome. And there's a bidirectional relationship between frailty and depression, but more early on our lifespan, between 40 and 60 years, than in late life. And finally, inflammation appears to be a key cornerstone in the pathophysiology of this association, including adverse outcomes like death. Okay, thank you again for following up me. Okay, thank you again, Sandra, and I left my contacts to here. Thank you. Can't hear.
Professora, a senhora não está com o microfone funcionando.
Okay. Okay, right now? I am? And now?
Desculpe, professor, eu estava falando com a professora Sandra.
Me ouvem? Sandra? O Felipe me ouve, pelo menos?
Sim, sim. Desculpa.
Você me ouve?
Sim, tá tudo
Será que alguém que está nos ouvindo pode confirmar que está ouvindo efetivamente, além da Sandra?
Eu acho que aqui, para nós, tá tudo certo. Só o microfone da professora Sandra que ficou fora do ar.
Será que alguém coloca no YouTube, tipo assim, estou te ouvindo? Yes, I'm listening to you.
O pessoal
Well,
tá
thanks.
falando que eles estão.
Okay.
So I can put some questions on the screen to discuss.
Okay. So,
see the question?
Yes. Well, Andrea is my Jerry fellow here. Hi. So, spectacular class. Well, you have a bias on that. Well, thanks. Is this association between low walking speed and cognitive dysfunction a new geriatric syndrome? Well, yeah. Some people used to call this the motoronic risk syndrome. And well, I think because we talked about cognitive frailty, this is a still weak definition. So we have to have better designed cohort studies to validate both internal psychometric properties and external validation. We have only external validation in this definition, so we have to have more evidence. If we look to the slow walking speed, it's a quite classical concept to increase mortality. So it's like we drink different types of liquids, and when we drink something that there's no taste, you choose, well, I think this is water. It's a good choice because no water, at least as I know, no water has taste. So if we don't taste anything, you can call water. So when we use the concept of low walking speed, it's good for everything. So it's good to incident dementia. It's good to higher burden of mortality. It's good to look at disability. So it's a non-specific outcome. Okay, hope to. Yeah. Okay, Dr. Ivan, excellent lecture. Thanks. In your opinion, which could explain the greater association between frailty and vascular dementia compared to Alzheimer's? Yeah, very nice. Yeah, also very nice question. Well, I see this in my practice. Most of my time I'm here in my private office, so I see a lot of patients. And well, my view is that the vascular burden, and for me the key aspect is the subcortex. The subcortex, the hyper high intensities that we see there is very, very much associated with slow gait speed, apathy, depression, cognitive impairment, and in a broader sense, we see a lot of global cognitive dysfunction, and I think this is why it's mostly associated with frailty, because frailty is, as you saw, is highly associated with depression, is associated with cognitive dysfunction in a broader sense. It's highly based in slow gait speed. So people with subcortex disease, small vessel disease, small vessel dysfunction, these people have a lot of frailty components. So that's why I think they are mostly associated. Okay, thanks. Another question here is, thanks for the class, thank you. What's the mechanism that explains the association between frailty and vascular dementia, but not an important zero? Well, I think I'm just answering that. And I think the rest, okay, the rest here is, yeah. Well, I think no other questions.
No other questions, Professor.
Okay.
No other questions.
Okay.
Can you hear
Okay,
us, Professor?
can you hear me now?
Yeah, quite and clear.
Okay, I changed the device in this time. So thank you again, Ivan, for your excellent presentation. I think that from the talks today, we can think about frailty, cognitive decline, depression, and other brain disorders as a big network. And I conclude that it's necessary to screen these conditions together. And I will repeat the question that I made to John. In the context of COVID-19 pandemic, how do you think is the best way to screen the older people, especially thinking about the commitments regarding the post-COVID syndrome? And do you think you will have soon a burden of dementia or cognitive decline? I think we will have the higher number of cases. Anyway, how to deal with all these problems?
Yeah, it's an excellent question, Sandra. Thank you again for the invitation and the question. Well, in the post-COVID-19 era, I think we have to mix easy instruments that we can have online, and at least we can do it alive, but at distance. We have to put this on the plan. And but we have to rely on good instruments with good psychometric properties. So what I recommend, it's my personal view, if you want to see frailty, we have to use the frail. It's more reliable. It's a very straight questions, yes or no, and you can talk in 1 minute to someone, and it's right away to use it. It's different from the clinical frailty scale that we have to have clinical experience. We have to read the rules to avoid misusage of the instrument, I think. But I think it's a good instrument, but I prefer the frail. For depression, I think we have to use the PHQ-9, which is the best instrument. It's a very much reliable, has a high level of correlation, almost 90% with the definition of major depression. So you can use it to subthreshold depression, also to minor depression too. The instrument gives you the instruction to make both diagnose. So it's a very nice and powerful screening instrument. And it's easy to do with patients online. I used to do this in my clinic, so it's good. And finally, how we can address cognitive impairment. So you have to use something that you don't have to use pen and pencil, or pen and pen, or paper and pen. And so I use pretty much the TAM cognitive screening. Is my favorite instrument. This instrument was developed by Daniel Apolinario, is a good friend of mine from the Faculty of Medicine and University of São Paulo. He developed several years ago, and is a very friendly instrument. The 10 CS, you ask about the date, you ask about recall of 3 words, and you do a verbal fluency test with animals. So it's pretty straight ahead. So it's easy. You can do this online. It's quite understandable. You don't use paper, pen, or any kind of tricks and trends that we can see with other instruments. So 10 cognitive screening, PHQ-9, and the frail. I think it's a triple combination, very nice to telehealth and to the post-COVID area. I think it's good choices.
Okay, the important thing is to monitor the older people, especially the ones that recovered from COVID. And I believe we have a big issue, both geriatrician and gerontologists to deal with in this scenario, right?
Yeah.
I think we have the last question. And
Okay.
then if anyone else, okay.
Yeah, this is nice. Nice to see you.
Do you want me to read?
No, I can see here. Hi, Shirley. She's asking about the existence. Evidence have pointed out the role of nutritional status, obesity, malnutrition on cognitive frailty, perhaps are risk factors. Yeah, well, we don't have the evidence good enough. But yes, I think we have a risk factor here because at least obesity is associated with inflammation, and we saw that inflammation may be associated with depression and frailty for sure. But we have evidence, although not so good enough, between cognitive impairment and frailty regarding inflammation. And malnutrition, I think it relies on why you are undernourished or malnourished. It's because you have cancer. It's completely different from anorexia of aging. So it's I think it relies on the cause of the undernourishing or malnutrition. And I can tell you all that we just submitted 2 research protocols for the Canadian longitudinal study of aging to evaluate obesity as a risk factor for sarcopenia and metabolic syndrome in the Canadian cohort. So it's I hope, Shirley, I can next year tell you all about our findings. Let's see. I hope that Canadians authorize our research from the Groningen University. Let's see.
Okay. Well, I would like to thank you again, Ivan, for your time, for our excellent talk. And some people are asking about the possibility of consult the event for today, and it will be available on the School of Public Health website to whom want to read again, watch again anyway. So I think today we have a great discussion about frailty and a lot of relationship with muscle, brain, and other disorders. I would like to thank the people, the audience, and to Ivan again. And thank you very much. I think we can finish.
Okay, thank you, Sandra. Very nice event as always. We're a great person, not as a friend, but a professor and researcher. Every time, every year, you do this movement for international events. So thank you very much again for the invitation.
Okay, thank you so much. Have a good day. Bye-bye.
Bye-bye.